Oh, there you go. That's good. Thanks.
So welcome, everyone. Thank you very much for joining us for the first webinar in our series. We're going to be hosting a webinar over the next year called Jumpstarting, the Conversation on Children's Health. And today's webinar is focused on what are the new resources for primary care practices around developmental screening, and what have we learned over screening over the last 5 years. My name is Amy Belisle. I'm a pediatrician. I direct the child health quality improvement work at Maine Quality Counts. And I am joined today by Dr. Steve DiGiovanni, who's also a pediatrician at Maine Medical Center Pediatric Clinic and the Barbara Bush Children's Hospital. I do want to note that our funding for the Developmental Systems Integration Project that we're going to be talking about is funded by the Maine DHHS through funding through the U.S. CDC Preventive Health and Health Services Block Grants. So just to remind you, Quality Count staff is working to improve the health of everyone in Maine. And we bring together the people who give, get, and pay for healthcare to address shared priorities. Our child health work is really guided by our Maine Child Health Improvement Partnership, which we call MECHIP. You'll see on the screen that there's logos from organizations from both public and private groups throughout the state who have been working with us over the past 6 years. Our mission is to optimize the health of Maine children by initiating and supporting measurement-based efforts to enhance child health care by fostering public and private partnerships. And our vision is that all practices providing health care to children will have the skills, support, and opportunities for collaborative learning needed to deliver high-quality health care. And our work over the past 5 years has really expanded from just working at healthcare quality improvement to working with partners across the community on child health issues. Just a few webinar logistics for Zoom. We have switched to a new platform from ReadyTalk to Zoom. You can mute your line or take off your video screen by changing the settings on the bottom box of your screen. If you move to the bottom box, there should be a gray line, and you'll see the mute and the stop video button. I have muted participants as they come in just to limit the background noise, but you can unmute yourself for a question. We do have a chat box, and you can put your chat into the questions to the chat box, and we'll address your questions as we go along. And we hope to have at least 10 minutes at the end for discussion about this topic. In terms of CME, we are offering continuing medical education credit for today's webinar. Today's speakers do not have any relevant financial relationships with the manufacturers of any commercial product or provider of commercial services discussed in the CME activity. We have CME for those who are signed into the live webinar. If you have multiple people at your computer, please type their names and email addresses into the chat box for attendance records. We do not have separate nursing CEUs, but you can get a CME certificate. And what happens is after the webinar, you'll get an email with the CME evaluation survey and SurveyMonkey. Please complete that within a week, and within a month, we'll send you a certificate. In that email, we'll also include a PDF of today's slides and a link to the recording on the website. So today's agenda, I'm going to provide an initial overview of the developmental screening efforts that have been happening in Maine over the past 5 years. We've done a lot of great work in the state, and we want to make sure that everyone's aware of it and the tools and resources that have been developed that we want to share with you. And then Dr. DiGiovanni is going to talk about the new Survey of Well-Being of Young Children SWYC tool. We've actually been mentioning this tool to practices over the past couple of years because it's been developed out of Tufts. And initially, it was getting categorized as a surveillance tool, but now it's been moved into the screening category, and there's a large group of practices that are now implementing this in Southern Maine. We want groups to be aware of what the SWYC is, how do you score it, and how, if you're hired, do you work with a practice that might be using the SWYC tool if you're using a different tool like the Ages and Stages questionnaire or the PEDS. They're all complementary, and we just need to be aware that they're out there and people are using them. And then finally, we hope to have time at the end to discuss how do we move developmental screening forward in the state, how can we continue to increase our rates and sustain the momentum. So we always like to start out with a little quiz, just to make sure that we're grounded on the screening rates that exist. So what percent of children in the United States are affected by developmental delays and conditions? And we say this because 10 to 20% of children are affected by delays and conditions, which means it's not a small group of children in our practices, in our communities that we're working with. This is important because as children go to school, many of the schools will tell us that they base their school budget on having 10% of the kids that might need additional services. When we first started working on this work, we were concerned because the percentage of Maine children entering kindergarten with unidentified special needs was closer to 20 to 30%, and that was significant because the earlier we can intervene in a child's life and get special education services, the better they will do. And then you may have noticed that in 2014, the number of children that have autism spectrum disorder increased to 1 out of 88. So there are several different types of screening tools out there. For developmental performance, which we should be doing at every well visit, we typically use the Bright Futures forms from the American Academy of Pediatrics. For developmental screening, which should be done at 9, 18, 24, or 30 months, many of the organizations of the state are using the Ages and Stages questionnaire, or the ASQ, or the Parents Evaluation of Developmental Status, or the PEDS. The Survey of Wellbeing of Young Children is now a developmental screening tool, but there is a large group of practices starting to use this tool in Southern Maine. Autism screening should be done at 18 and 24 months, and that is usually done with the MCHAT, the Modified Checklist for Autism in Toddlers, and that's validated from 16 to 30 months. I do like to highlight, in the past, people have said, well, you can just wait till the child gets older and we'll see how they do. And waiting really shouldn't be the option at this point. Surveillance detects less than 30% of children with developmental disability. The parent-completed tools have a 97% accuracy rate. Parents do know how their children are doing developmentally. As I said earlier, children are identifying schools with identified needs. And the schools need to be ready for the kids, and the kids really need to be ready for the schools. So it's important to identify them early and get them to early intervention services. Just some brief background about what's happening in the state. There's actually been a lot of work happening on developmental screening across the different sectors in the state. Back in 2010, we had a federal CHIPR grant, the Child Health Improvement Reauthorization Act. Maine and Vermont got a 5-year grant to work on improving health outcomes for children. At the same time, the federal government released a list of quality metrics, and developmental screening was one of those CHIPR core set measures. And that put it on the radar because the state actually has to report to the federal government how they're doing on developmental screening for children enrolled in Medicaid. In 2012, we launched a pilot, a learning collaborative around developmental screening with 12 sites called the First Steps Pilot. Then in 2012, at the same time, what we realized is we were doing work in the practices to improve developmental screening. But when we started to do that, we realized that there was a lot of partners in the community that were also doing screening, including our public health nurses, our home visitors, Early Head Start, CDS, and we really needed to coordinate our efforts across these organizations to, one, share information to prevent duplicative screening and make sure that children got to the right service. So we actually got funded through the Maine CDC and the Preventive Services Block Grant and Home Visiting to start a project at the systems level to address this called the DSI project. For those of you who are part of the Health Homes and Patient-Centered Medical Home work, you probably remember in January 2015 that you were started to require to implement developmental screening. And at the same time, there were claims-based rates that were put on the Maine Care Utilization Review Report so you could follow how you were doing. Between 2014 and 15, we trained over 100 practices in developmental screening across the state. And in 2015, we worked with 3 communities, Waterville, Bangor, and Midcoast, on trying to pilot how do we communicate screening across the different partners and how do we improve the system at the local level. And currently, Maine Quality Counts with their partners are working on exploring the Help Me Grow model, which is a national model around care coordination for young children ages 0 to 8. So I want to show you this slide because it shows the great work that people are doing in developmental screening. This is the Maine Care claims data from 2011 to 2015. When we first started the developmental screening work, our rates for ages 1, 2, and 3 were only 1 to 3% for developmental screening. And this is practices who saw a child and then build a claim to Maine Care for developmental screening. Over the past several years, we've increased our rates to 21 to 28%. So we've actually seen a huge increase in the number of screenings for children enrolled in Maine Care in a short period of time. So while we're seeing great rates, we also know that that's saying to us that 70% of the kids are not getting screened, and that is still a concern. We do know that there are groups that are doing screening, like Early Head Start, Maine Families Public Health Nursing, and they don't give a billing code to Maine Care for that service. So there are other ways to get data, and our rates are higher than this, but they're still probably only in the 40 to 50% range, so we still have some work to do. Some of the resources I just want to make sure that people are aware of. When we started this work, we developed a common terminology chart. When you're working with a lot of different partners and practices, not everybody was talking about the same thing for screening. We first started talking about developmental screening. We heard, oh, we're doing screening, but what they were really doing was surveillance with Bright Futures. So I'll show you in one of the next slides what the chart looks like. There's also an updated Maine Care billing codes for oral health and preventive screening. Maine Care pays for developmental screening, and I'll show you those codes in a minute. People should be aware that the billing code sheet was updated in June of 2016. Back when we first started the project, Maine Care actually purchased a universal license to the Bright Futures Toolkit, the 3rd edition, and the AAP Autism Toolkit, and that is available to all Maine providers. You can get a passcode from Maine Care and access the web-based version of those toolkits. We are aware that the Bright Futures Toolkit will move to the 4th edition sometime in the next year, but currently we have the most recent version. We've also been testing a universal sharing and consent form from the primary care practices to provide information to their community partners for a referral form. This has been a challenging piece of the work because when we first started, everybody said, well, if there's just a way to communicate the results to all our partners, this would be so easy. We would reduce duplicative screens and improve communication. It's proved to be challenging because every different organization has their own consent form, their own legal requirements. So we did come up with a trial form to use with the primary care practices at the different community sites. Just so you know, CDS, or Child Development Services, does have an online referral system for children they would prefer people to use. And what we're asking practices to do is at the same time that they refer someone to CDS to also sign a consent form that allows CDS to share information back to the practices about the referral. We've also developed a list of resources around early intervention, and those are on our homepage. A few more resources that you might find helpful is one of our project managers, Nan Simpson, developed several handouts on why developmental screening is important, just a one-page overview for both families and staff members when they're implementing screening. We've also collected practice workflows and developed a change package, a list of best practices to help guide quality improvement work. And we've mailed out to over 500 practices the first steps periodicity chart and poster, which lists out the different required screenings and at what age. I'll also show you in a minute, we've been trying to distribute materials from the CDC's Learn the Signs Act Early material. We've mailed out brochures and magnets to over 500 primary care sites in the last 2 years. This screen just shows an overview of the change package for developmental screening that's available on our website. There are the key changes, and with that, there are different pages that align with that to provide guidance to practices around how to implement screening. This chart is the terminology chart, and I just want to make you aware of this because when you're working with different community partners, surveillance, screening, evaluation, and assessment might mean very different things in the medical world versus an educational world. So we worked for 6 months to try to come up with a similar terminology that everyone was understanding when we talked about screening, evaluation, and assessment. Next, just so you're aware, Maine Care does pay for developmental screening with the 96110 code, and they just revised this form in June of 2016. There's an $8.99 of reimbursement. They're also paying for the MCHAT screening. They pay for a brief emotional behavioral assessment, and they just started to cover tools around postpartum screening for depression. They also cover adolescent screening for depression. For those of you who are doing photo screening, doing vision screening on children, they do reimburse for that, and they have divided those codes out between those instruments that have a remote reading and those who have an on-site reading. There's different reimbursement rates. And I say this to you because they just recently increased the reimbursement rates this summer. They're also paying for fluoride varnish and an oral evaluation if you're doing that in primary care. There's a lot of materials available online around developmental screening. You'll see the Learn the Signs Act Early material, and also the Federal Department of Health and Human Services and Education has developed the Birth to 5 Watch Me Thrive series, where they have a lot of materials for both families and provider organizations. This is the First Steps periodicity schedule for primary care. You could download this from our website. We've also mailed this out to many practices. It was revised about 2 years ago, and we're currently waiting to see if there's any revisions in the new Bright Futures manual to see if we need to make changes to this schedule. You'll see when a suggested schedule of screenings to be done, when they're required by Maine Care or Early Head Start, and then the reimbursement rates. And this slide shows the checkerboard that says your child's early development is a journey. This is the federal CDC's Learn the Signs Act Early material, and we've sent this out to practices on both poster and magnet forms for parents. So happy to have you. If you have questions for me, put them into the chat box. I'm going to turn this over to Dr. Steve DiGiovanni. He's the Medical Director of Maine Medical Partners Outpatient Clinics. He's going to talk about the SWYC tool, the Survey of Wellbeing of Young Children. And he's going to talk about what they're doing down at Maine Medical Partners to try to improve the screening rates.
All right. Well, I'm very excited to be here. Thank you for having me, Amy. Trying to share my screen. I'm not sure if you've logged out there. There we go. Thank you. All right, so basically the presentation about the GIVE is kind of similar to the presentations that we've used throughout the process for the sites for education, but also for leadership to try to get some support behind the process that we're working on. So I work in the outpatient clinics, which is the residency-based clinic here at Maine Medical Center, but we're a part of Maine Medical Partners. There are 6 other pediatric sites and 5 family practice sites that all serve children. So up to this point, Maine Medical Partners is really only doing developmental milestones, and so a lot of it, as Amy highlighted, was teaching leadership and the sites the difference between those two, and then putting out that it is kind of highly recommended by the 3 listed there, and that it was being paid by Maine Care.
Lizzie, are you seeing the screen share?
Me?
It's not sharing right now.
No.
Hit the green button one more time.
Hold on, when I went to I can see you, Amy, but I lost when I went to my PowerPoint. I lost the green button.
Okay. Can you see my screen now?
Yeah.
Okay, I'll advance your slides.
Okay. Thank you. Yeah, I don't know what happened there. So go ahead. Next one. So probably preaching to the choir here, but that pediatrics and family practice are incredibly well set up. We see the kids a ton in the early age group. We have a very trusted relationship. Parents, it's a pretty comfortable place to try to really talk about some of the more difficult things within developmental screening, but just also within the family, whole family review. When we talk to providers, we obviously know, yes, insufficient time, limited resources. And I would also just put in, that some quality gaps and holes in our training in relationship to developmental and what I would consider kind of family / socioeconomic screening. Go ahead. So one of the, when I started looking at the screening tools, one of the concerns I had is that that really was specifically focused to where that child was from a development at that time, but did not really look at the whole environment around the child. And so that's one of the things as we started to look at the SWYC that really attracted us, because it does start to pull out some early issues around possible risks for obesity, ADHD, anxiety, depression, mental health issues. But most important is it really looks at behavior, emotional, and family functioning, and starts to get at some of the adverse childhood events data that we've really, at least in my practice, have not gone after before. Good. So just to give a quick background on some of the adverse childhood events, large study by Folletti and Anda back in the late 80s, early 90s, looking at about 20,000 adults and really looking at their adult health and then comparing it to what are defined as adverse childhood experiences. Found that very much that these were common. This was a kind of middle class to upper middle class insured population. And as you can see, three major areas: household dysfunction, abuse, and neglect. And the ranges, like in household dysfunction, ran from about 12% up to 30%. And this is talking about living with a parent with substance abuse, loss of a parent through parental separation or divorce, living with a parent with mental illness, exposure to domestic violence, or having a parent who has been incarcerated for criminal behavior. Then there was the neglect, either physical or emotional, and then abuse. And so those, and the other thing to point out is these come in groups frequently, that about 20% will have 3 or more, and you'll see why that really makes a very large difference. So the message is basically here, these are significant events and they're common. Go ahead. Another study came out of Philadelphia, so I just wanted to give a more up-to-date study for 2013. Huge, big data numbers, which I don't have in front of me right now for the numbers of people they tracked. But they did a standard ACEs and they did a urban ACE score, which added things such as exposure to violence, like in the neighborhood, bullying at school, experiencing foster care, and there was one racism-based question. And so you can see that, especially for the 4 or plus ACEs, very, very high rates. And this study in Philadelphia took in suburban and urban mix. It wasn't just a core urban study. So once again, similar message, a lot of kids being exposed to a lot of difficult things in childhood. Why is this important? A lot of research, and the AAP's put some really excellent toolkits out here showing that long-term and significant brain changes when you're exposed to toxic stress. Everybody's exposed to some stress, one-time events, and you have a resilient or supportive parent. That actually frequently can be good for the child's long-term functioning and development. When you have ongoing high-level toxic stress, so say living in a household with ongoing domestic violence at a young age, there's been shown to affect the amygdala, the hippocampus, the prefrontal cortex, leading into impairments of memory, mood, and then really that executive function. And when you look at this, it really puts a weak foundation for learning, behavior, and growth. And so this is kind of the approach that when you're looking at developmental screening really kind of jumped out at me. And once again, I tried to highlight really the importance of having that protective adult in the lives of children. Go ahead. This is the kind of social public health model showing child's exposed to adverse childhood events, social, cognitive, emotional impairment, adoption of high-risk behaviors, disease, disability, social problems, and early death. And then a lot of when you're exposed to high and frequent stress, the child will really live in that fight or flight mechanism. And so in addition to kind of the brain changes, you also have just a constant daily experience within the body. Go ahead, Amy. What I try to do in the next slides, we're going to kind of fly through them, but really show some of the ACEs data and why I felt it was important to kind of go after the whole environment and not just where the child was in the developmental screening. What you'll notice on the slides is it'll be number of risk factors or ACEs along the bottom with the risk percentages going up with the child having whatever is highlighted. This is developmental delay. This is from I can't remember if it's federal CDC, which federal database I pulled it off of. It's in my notes section. But basically, you can see that rapid rise. So if the child had, 1 to 2 ACEs, you're talking, it's like a 5 to 10% risk of developmental delay, and you get up to 4, we're at 40%, up to 5, we're at 70%. So just an incredible kind of marker for risk there, and you can see that nice stepwise increase also. Go ahead. Similar study, smaller, but I found it was kind of powerful. And in thinking about what's going on in a lot of our schools, I do see schools moving in this direction. But basically, adverse events across the bottom, academic problems across the top, and that same very linear stepwise approach. And so if you had 2 or more reported adverse events, the kids in this specific public school had up to 70% rates of some academic concerns. Go ahead. Similar increase in smoking. So look at one of the still number one killer and long-term health cost. So rising from 6 to 7% for 0 to 1 to a doubling when you get up to 4 or 5 ACEs at 12% in this particular study. Go ahead. This one leaps out at me. We have a huge drug problem and opioid crisis in Maine. It just kind of gives you a different lens to keep on when dealing with parents who have drug addiction issues versus prevention in children. Each bar along the bottom shows you the ACE score, and just that, kind of how protective it is if you've not experienced them. So we're talking about 0 to 2% or lower, and then how it leaps up. And especially when you look to that 5 and above and the addicted to drugs or injected drugs data. Go ahead. Once again, similar data around suicide attempts with a kind of almost protective at 0 or 1, and then rapidly rising to impressively high rates at 3 or 4 ACEs. Go ahead. Staying in the pediatric age group is teen sexual behaviors, and you can see once again the consistency of the data and the rise. And it's significant. If you did odds ratios on these, it's utterly impressive. Go ahead. This one came out of the Philadelphia study. I just wanted to highlight it just to kind of show the power of ACEs and versus kind of poverty level when we're looking at health disparities. And I feel both obviously are important to address. The first on the left is below 150% of the federal poverty level, and then 0, 1, or 2 ACEs and a mental health condition diagnosed for the people in this study. And you can just see that large leap from 11.4 to 35% for 4 or more. The rates are a little bit lower for the greater than 150% comparatively, but just as much of an impressive rise that you see as the ACE score goes up, and then combining the two, you stay with that nice stepwise increase. So it hits all socioeconomic levels, and it has an effect on children's growth, development, and long-term outcomes, no matter what where they fall within socioeconomics. Go ahead. If it's okay with you, Amy, can I open up for a few questions? That's just kind of the intro section. I think you're still muted there, Amy.
Unmuted the line. If there's questions for Steve, please be aware that some background noise, and you can mute yourselves at the bottom of the screen.
Yeah. Yeah.
Any questions for Steve?
But yeah.
I'm going to mute the lines again because there's a lot of background noise too, so I think you can keep going.
That's fine.
Questions in the chat box, let us know, and we'll take questions at the end.
This is the SWYC developed out of Tufts, and it's still ongoing development and research on the tool. It is open to being used. It does not require any cost or copyright utilization, which is very nice. Great group, and we can share the website out if they've been supportive for us in answering questions and things. Their symbol is the circle. It's the idea of really taking that whole family, whole child approach. 3 major sections: the development, which is the milestones, questions, and also has at the appropriate ages an autism screen, which is the parent observation of social interaction. Then one of my favorite sections really is the behavior and emotion, or the pediatric symptom checklist. They do a baby for the BPSC and a preschool version, and we'll look at those. And then the bottom section is the family stress. It really matches a lot of the kind of ACE work in trying to get at some of that data and initiating conversations with our families. Go ahead, Amy. So as I said, it's free. It's longitudinal screening. They have it available from basically, I think it's a 1 month all the way up to through the 4-year visit, and there's one specific for every visit. We're using 3 of them now, really at the 9, 15 or 18 month and the 30-month visit. Like most screening tools, this one has a higher, like a nice high sensitivity. Their goal was not to miss children. And so it was around, in that 90 to 95% across most of the different sections. And like many of our other screens, has a lower specificity, meaning it's demonstrating risk, but it's not diagnostic in any way. And further diving in with conversations or other tools is important. It also, what I love is the frequent opportunities to build protective factors and resilience in parents and children. And then what we also did with this, like for our behavior and development specialists down here who are way backed up, there was concern that we were going to flood them with referrals. And realistically, that's not the case here. Generally, what I find it falls into 3 buckets equally, between referral to like behavior and development, referral to our behavioral health clinicians. Luckily, we have some integrated ones in our practice, social workers, referral to CDS, and or just follow up with the pediatrician. If you have an integrated behavioral clinician, it really makes an immense difference. Go ahead. So I'm going to walk you through the tool. It comes on front and back, and I'm just breaking out the different sections here. The developmental milestone section, this is the 6-month one. We use the 9-month. The questions start out easier, meaning most children at 6 months should be able to do what it is asking about, and the parent fills out the not yet, somewhat, and very much. And then as you go down the questions, they get harder, where most 6-month-olds are probably not doing it. What I like about that from a residency teaching program is our residents then know what to talk about with the parents, things next to work on. Amy, can you start hitting some of the buttons? Yep, go ahead. Keep going. Yep. So you get a score of 10, and there's a sheet I'm going to show later that for each age, so say you were doing the 6-month-old, but if the child was actually 7-month-olds, there's a cutoff. And if it's below that cutoff, it goes into the needs review category. So it takes seconds to score. And there's an adjustment if the child's more than 1 month old, 1 month premature. Go ahead. The baby pediatric symptom checklist, hit the 3 subscales thing. So this really hits on a lot of parenting, which I think is fantastic, and really helping parents kind of move forward in helping with development, but also helping their child's social and emotional development. So really looking at, does a child have issues with new places? Is a child inflexible? Are they having a lot of irritability or difficulty with routines? We get a lot of hits on this one. In general, if it's 3 or above, so if you want to hit the scoring. Oop, that was back one, sorry. So basically, if it's 3 or above for any of these, it counts as a positive. But if they're hitting very much in any of them, it's a great conversation start. For many families, we've then pulled in our integrated social worker set up a follow-up meeting just to work on some parenting, 1 or 2 visits, and we seem to be like in a much better place. So it's been a nice early pickup on issues that a family is having. There is a preschool pediatric symptom checklist, looks very similar, scored a little differently. Go ahead. This is the autism screen, the research, and in their on their website and in the manual that can be downloaded for free. It goes through all the research. Does seem to compare similar to the MCHAT, not the MCHAT 2 level, but just the initial screening MCHAT. We haven't fully replaced the MCHAT in our organization yet. With this, it is something we're going to be looking at because I think from an efficiency point of view, the providers will be very happy, and then maybe using the MCHAT and MCHAT 2 as a backup tool. Go ahead, Im. So any checks in the red box go into the concern category. And you can see the questions: does the child bring things to show you? Is the child interested in playing with other children? Look at you when you call his name, and then at the bottom, kind of talk about how the child indicates wants and what some of the favorite activities. Go ahead, Amy. And so this one scored, oh, keep going. So a 2 is under the cutoff of 3, which would count as at risk, and you would then either follow up with increased additional questions or using an MCHAT. Go ahead. Just want to highlight as we're going through this, there are 2 questions about parent concerns I didn't put up here, but basically ask if the parents have concerns about behavior or if the parents have concerns about development. The other thing I like about the tools, you've hopefully noticed, is the questions are short, and they're, you don't need any type of, you don't have to demonstrate any of the things to the parents. It's all things that parents normally do, no matter their culture, pretty much, I found, which is great, as we've had some issues in our clinic with the MCHAT and the ASQ with trying to use it with different cultures at points. And the literacy level, I think, is at the accurate level. This one looks at family questions, and this is where you get additional kind of ACEs screening. What they did is they took validated tools and smushed them together. We're going to skip the smoking question because that's handled elsewhere usually. But basically, there's 3 questions that are validated around substance abuse for the parents, which if we can get at some of that data, I really think would improve the health for the children. Have you ever drunk or used alcohol more than you meant to? Have you ever wanted to cut down? Has a family member's drinking ever had a bad effect on your child? And obvious, a yes for any of those is a positive risk. The next question is an excellent screening tool for stress on a family, really looking at food insecurity. And there's a lot of data showing if a family is struggling to put food on the table, the amount of stress for them to do all the other things additionally in their lives can be very, very high. And so trying to provide additional supports. And it's not just about getting, I mean, obviously we can, as best we can, to get them supported from a food point of view, and accessing resources in the community is important, but also using it as a signal for stress on the family. The next is basically the PHQ-2. We do already do postpartum depression, and the research says we should be doing that kind of screening ongoing. It doesn't pick up other mental health issues, obviously, for the parent, but at least I think it's a start. And then the last questions as a kind of first step really into looking at kind of risk for domestic violence. And I think it's a good way of starting down that that path. It's a lot of times we ask for about safety. We don't get a lot of positive hits on that question, but we know domestic violence rates are significant in the state. So this one does is it looks at describe the relationship: no tension, some tension, a lot of tension, and how do you work out arguments? No difficulty, some difficulty, great difficulty. A lot of tension or great difficulty are the positives, but obviously you could have a conversation with some tension or some difficulty also. And Amy will kind of fly through the scorings. We then took, back one. So for when we rolled it out to the practices, we gave them this scoring guide, which showed you for each of the months that we were doing what the scores were. So if the kid came in, you could see if the kid came in at 9 for the milestones, the first category, So 11 or below needs a review. Obviously, 11-month-old should be doing more things, so it's 14 or less that needs a review. And then it gives you a quick reference for all the other scoring. And then we also, on the front side of the sheet, put it in the actual like sentences, how to score, just depending on the learner. We then laminated all of these and put them in every exam room and in the workstations for the providers. Go ahead. Next section, just want to kind of talk about how we rolled it out across the system. Basically, we started with a provider work group to determine if we were going to use the SWYC, the ASQ, or the PEDS. We looked at all three, and the pediatric provider group, of which was 6 representing multiple practices, was able to, ended up choosing the SWYC, so it was nice to have that kind of support behind it. Maine Care, we were then able to work with Maine Care, who then approved it as one of the developmental screening tools, along with ASQ and PEDS. And then we basically did a lot of trainings, and really some were pulling together like all of our pediatric providers and giving them the background. We also did all of our behavioral health integrated clinicians and leadership, and then went out to each of the practices, because these are different types of questions and different type of data than we were collecting previously. So we wanted to be on site and answer as many questions as we could. In addition, we provided them like a 101, one-page, 2-sided thing, like intro to it. We provided them the scoring sheets and the manual. Go ahead. So right now we're doing it 9, 15, and 30, because at this point we kept the MCHAT at 18 and 24 months, so that's why it's set there. We distribute it at check-in. It's scored by the clinical staff, and then the idea is it's reviewed and acted upon by the provider. And then we have our referral resources available, and I think a lot of the work that Amy Belisle and her group has done with like Child Developmental Services and other community partners really makes a difference for rolling this type of thing out. Go ahead. This is just kind of like, we actually put together like very specific communication plans to make sure everybody was on the same page across the organization. As I said, it was 11 practices that we were trying to roll out in about a 3 to 4 month period. We did pilot at 2 practices, which made a large difference. So we were able to kind of work out a lot of the tweaks and get feedback from different people prior to the bigger rollout. Go ahead. And that just kind of shows you some of the specifics of how the trainings went. And we also then provide support by email and gave phone numbers to our administrative lead and myself to respond as best we can. And we're I guess about 100 staff or providers trained. Go ahead. This gives you kind of the actual workflow. We smushed it onto a PowerPoint, but basically there's arrows and things on the official one. And you can see, every member of the staff is generally affected when you put this type of workflow, from your PSRs to your clinical MARN or LPN, your provider and or your scanning staff. We're on electronic medical record. It is not built into our electronic record, so we built some quick tools and shared them, and you'll see the one that says .SWYC 9-month-old, and basically that embeds a kind of summary scoring. So we don't put all the questions into the EMR, we just put whether it needs a review for the different sections, and then it has a little assessment and plan, so it's quick. And then we ask the practices to not complete developmental milestones, and that's the time saver. Like up to this point, typically the MARN or LPN was spending, minutes going over to developmental milestones. If the parents are able to complete this ahead of time, you've saved time there at least. We have a lot of issues in our own clinic because we have greater than 50% English as a second language, so we have to schedule additional time for this. The practices that do not have not needed to schedule additional time. One of the other teaching points I like to mention for practices that if something major comes up on this, throw the well child out, just focus on what the major issue is, and then reschedule, for a well child in the future, because you can't do it all in that one time. And then the provider basically, as I said, enters what the plan and recommendations are, what the follow-up options are, enters the bill. We're trying to get the billing built in cleaner than it is, And then we do scan it because it is something that is charged to insurers. You can skip this one because you already kind of... Our hope is to end up actually building it in the electronic medical record. That's a big build. And what we'd like to do is have them enter the data either like via iPad or from home with email sent out prior to the visit. We are going to track our QI metric this year to see what rates we get up to. All practices went live by September 30th. And we're working to, a big component of the long-term process here is the integration of behavioral health into this. And they've been a good, very supportive team member. Angela Lawton is our contact at Maine Health who's been helping, and she has a lot of the tools and things available if people want to send her an email or myself. Feel free to share my email also, Amy.
Okay. Thank you, Steve. We wanted to have a discussion with folks on the phone, and I'm going to open up the line. So I just want to pre-warn people because we might get a lot of background noise. For questions for Steve, as well as a discussion about how things are going in the state around developmental screening, what challenges you might be facing, and are there barriers or challenges that potentially we could assist you with as we talk with our statewide partners with the Developmental Systems Integration Project. So as I do this, I'm going to unmute all of you, and if you have background noise on the bottom of your screen, you can just mute yourself. The questions for Steve first about the SWYC screening.
Steve, this is Kim Fox. Can you hear me?
Yep.
Hi. I just wanted to know, Steve, have you done any comparison of like what numbers of risk you're identifying with the SWYC that you may not have identified with the other tools or anything like that?
Not yet at this point. I mean, basically through talk mostly through the pilot. We piloted here at the pediatric clinic and at Falmouth Pediatrics. And so really just a lot of it was, I don't have the specific percentages at this point. I haven't had the resources to go after that. But I would say just from working definitively the pediatric symptom checklist was a big kind of gain in information that we didn't have before. I've had a few patients with the relationship one does trigger some conversations, and I've been, trying to work with my integrated clinician about, how we handle those and trying to do the best we can there. So definitely getting new information than we got before, but I don't have the data. The SWYC group they've been very data focused, and on their website and manual, there's some nice information there.
I guess I also would follow up and say for the, because those family questions are new, are you getting any reactions from the, the patients themselves in terms of those questions? And another challenge I would imagine is that some of the parents, I don't know how you do follow up on the parental side if they don't have insurance, or they don't have access to being able to get other services. I'm just kind of wondering how you dealt with those challenges in the pilot.
We're relatively blessed here in that even if they don't have insurance, we're relatively blind to that. And so our behavioral health clinician will work with all comers, and we can usually through free care access child psychiatry resources. So it hasn't been as much of an issue for you. For us, haven't had a lot of negative reactions from parents. What I didn't show on the tool is each section has a nice little introduction of why we're asking those questions, which I think is helpful. We have what we call SWYC 101 tool that we sent out that works with staff of how to kind of talk about the tool a bit. So I've not, at least personally, had negative feedback. We tried the pilot, as I said, in Falmouth, which has a higher socioeconomic. And we also pilot in the pediatric clinic, which is about 96% main care, and then an incredible mix of cultures. And we did had an intern who interviewed a bunch of our interpreters around some cultural competence with the tool, and just as best we could, from at least doing small focus groups that way, they were supportive of it. We did not get a lot of negative feedback, which was great.
That's great. Thanks.
Steve, this is Amy. Have you seen your rates increase from the number of kids being referred to child development services?
Once again, I don't have the data yet. Our data team right now is building out the reports just to get our screening rates, and then second level reports, in the next year or 2 years, would look at probably like, okay, well, what's happening once we get positive scores, and how often are we getting them to our integrated clinicians, or where are the referrals going? But no, I don't have that kind of data.
And in terms of the community partners that you're working with, what is their reaction to the SWYC? That if you're sending them over to see them, have they had any response, or are they just starting to see this in the community?
I don't think we're seeing a different. Whether we do it this way or otherwise, I think from a developmental screening, it doesn't change very much whether I'm using CDS or child behavior and development. What I think the bigger difference is I'm accessing mental health and behavioral health resources at a higher rate than I was previously, in this age group especially.
Other questions about the SWYC? Has anyone on the line started to use the SWYC in their practice? Any experience that you want to share?
This is John Famberg. I can throw out some experience. So we've been using the SWYC maybe for about 3 weeks at most of the South Portland Pediatrics. It feels like it's a very useful tool, and the fact I can glance down and get a pretty good image of what's going on. We've been screening everybody of those age brackets, and there's times where I look at it and say, oh my gosh, there's a load of stuff going on. And then look at the chart, and notice the kid's already been diagnosed with autism and is already seeing counselor intervention people along those lines. And so we're probably over-screening a little bit in the process for people where we already know issues exist. And then I can also say it does take a tiny bit more time than previously. And maybe it's just because we're still working on the flow 3 weeks in, but it does take a little bit more time getting the data initially. It'd be great to have it online before they come in, but we're not there yet.
And how are the families reacting to the tool, John?
No differently than all other developmental questions we've been asking so far. It's my impression. I haven't had any loud drug, alcohol use in the parents show up on a SWYC yet, so maybe I haven't got the sensitive ones yet.
In terms of how we continue to move developmental screening forward, so some groups have been screening for many years, some are just starting. We're trying to continue to think with our partners at the state levels, what are some of the barriers or challenges to screening? Are there things that we can work on at the system level to improve the experience for patients at the practice and community level? And I don't know if there's anyone that has any thoughts about that, what challenges still exist.
I would just like to kind of back up John's statement, the fact that we're still in the relative dark ages and using paper, and we're not, we don't have the system built that, any iPhone or computer to get this data in even before the patients get there, or using a kiosk method in the waiting room. So that's for us, I guess, what we're looking for.
Yeah.
Amy, I'm not answering your question. This is Kim again, but Steve, you said that I know that Maine Care allows you to code the SWYC or accepts it as a screening tool, but is there, if you wanted, because the SWYC sounds like it actually has additional questions beyond developmental screening, and it does get you into the whole mental health, behavioral health area, if we wanted to be able to measure, those folks that were choosing to use SWYC versus the other, is there a way that it's being coded? I hate saying this, but because I know people hate those modifiers, but it won't be captured if it's just under that general 96110. And I'm just trying to think ahead. I thought you had a diagnosis code on there, and is that potentially different?
Yeah, there's been, I struggled with our coding department in determining exactly how to drop the bills and code it, and there is a modifier they want us to put on, which has caused additional issues and problems with the providers to code correctly. The ask is in that we get one button that when we click it, we get credit for it, and it drops the bill and the modifier. So that's been probably one of the more frustrating parts of the experience so far to get clearly done.
Yeah, I know. I hated even bringing it up because I know it's a problem operationally. But I'm just trying to figure from a, purely measurement perspective, if you wanted to see how those more broadly it's being used. Maybe it's just knowing the systems or the practices that are using it and isolating those rates relative to others.
Yeah, so our system, like we were very clear with the practices once we made the decision, this is the one we were going to, and so
right.
Our practices are using it.
Thanks.
Yep.
Any other thoughts from people on the phone? What we'll say is we're thinking that we did trial with the Developmental Screening Community Initiative, the ASQ Online tool, where we had the community partners, they were all interested in entering their ASQ results online and then potentially be able to share it. We thought it would go smoothly, and it was really challenging to even get it into place. It took many, many months, partly because all the different community partners and health systems were on different electronic records. There was an issue around who was going to be the person that really managed this in the community and gave permissions and did the troubleshooting. We thought it would be something smooth that would go in the first couple of months, and by 8 months would really work well, and it really was challenging, and it was hard to get off the ground until the very end of the pilot. So I think it's something that we're still struggling with, and there are other tools out there that are portals where you can put in information about your child's health, but they're just not integrated with the EMR yet. So it's that needing to integrate with the EMRs and share data that's really critical here. Other thoughts? I know we're getting close to the end. I do want to share with folks on the phone that we do, through the Developmental Systems Integration Project, have some technical assistance available to community organizations and practices around a developmental screening implementation at your sites. If you have questions or would like to talk with us more, feel free to send me an email at Maine Quality Counts, and I can connect you with our quality improvement coaches. We have gone out to do on-site technical assistance visits, as well as just virtual discussions through either email or Zoom or telephone calls. So we're happy to offer that to folks. I think that we still have a fair amount of work to do in the state to get our rates up, because we really want to make sure that all kids in the state are getting screened. Right now, we can tell through the Maine Care data how we're doing, but we don't have the data from the other insurers, the commercial insurers, to see where all of the children are doing in comparison. So I think there's still a fair amount of work to be done in the state around screening, but we're really actually delighted that we've seen so much progress in a short period of time. For our rates to go up 25 to almost 30% in a 3 or 4 year period is really amazing. So we're delighted with that. We just know that we've got to continue to work on this over the next several years. So I want to thank Steve. And Steve, do you have any parting thoughts for us as we end?
No, just appreciate it. And we'll hopefully be doing some more in the future.
Great. I'm going to just go through the last couple slides. We do have a webinar next month with Dr. Barb Frankowski from Vermont and Nancy Cronin of the Maine Developmental Disabilities Council on how do we create friendly office spaces for adolescents and children with special healthcare needs. So please join us. It's always the second Thursday of the month with the same Zoom line, and CME will be available. Just as a reminder, we do have CME. There's no disclosures today for the speakers. You'll be getting a link from the SurveyMonkey after the webinar. We'll post the materials online and the recording. If you have any questions, you can contact Lizzie White at Maine Quality Counts. So I want to thank you for everyone today. We do have resources posted on our website. And if you have resources you want to share with us, we're happy to post them on their website around developmental screening as we try to build that resource out. And we do have several consultants working on the project with us, including Sue Mackey-Andrews, Sue Butz-Dyan, and Peter Rao, who's a pediatrician down in Portland. So thank you very much, Steve, for joining us today, and thank you for everybody on the phone. We're delighted to have you, and we look forward to seeing you in November.
Thanks, Amy.